First speaker, we invite our good friend and well-known surgeon, especially in refractive surgery and cataract surgery, Dr. Jorge ALIO. His speech is its role in modern refractive surgery. Ladies and gentlemen, let's welcome Dr. ALIO.
Thank you very much, Dr. Ryan. And this is my presentation will deal now about refractive surgery of the crystalline lens and cataract and this role today. I have no conflict of interest about this presentation, even as I'm a consultant of some companies dealing with intraocular lenses, but not about the topic, which is purely refractive lens exchange. First, we're dealing about the refractive elements of the eye, and one of the most important, together with the cornea, is obviously the lens, and the lens governs part of the functions of the eye, especially in young persons, by a variability in the focusing capabilities. Because a lens is a complex structure. It has different logics, has different index of refraction depending on the area, and has a role in focusing the light in the retina, and especially during the process in which we can focus according to distance to model and to get a monofocal image in every type of distance, changing the power of the eye according to ciliary body action. Ciliary body action is indeed part of the effect that we have in aging when declining, and indeed this is why a crystalline lens takes a role in the middle age of the middle stage of the life in order to govern the vision and later on to take decisions by the surgeon in terms of how to correct the presbyopia. So the function of accommodation is with the one that has been more intriguing, and the theory that is at this moment much more accepted and partially is the one that has been demonstrated, is the von Helfeld that announced his theory in 1856, in which due to the ciliary body action, active ciliary body action, we have a change in the power of the eye according to distance. This is accommodation, and accommodation depends on factors that are affected by aging. So the accommodation is any other reason by which we can focus not related to the change in the power of the eye, and we have to remember that depth of field and depth of focus are the ones that are today more in fashion in terms of using by different types of premium lenses. Depth of focus is defined as the conjugated plane of the depth of field in the image space, and to certain limits this can compensate in part accommodation. We have to remember that multifocality in the human eye doesn't exist. Multiple focus images are created by the division of the light energy in different focuses when it happens in multifocality. Overlapping of retinal images is not desirable because the dispersion of the light energy has a negative impact in contrastivity, and always this happens to be with a negative perception of the quality of vision. And the normal manipulation of the light in multifocality induces optical abnormalities that are perceived by the patient with different light vision phenomena, which means that this multifocality needs to be adapted to the brain, and the adaptation has to follow any multifocal activity because we have not a multifocal brain. Lens surgery, today we are attending in a paradigm shift. Paradigm shift is happening because the aim of the surgery until recent years was to restore vision in aphakia. And the purpose was the surgical procedure was to get vision, and the residual refractive errors were to a certain extent acceptable as a trade-off for vision restoration. No longer this is true because today improvement in the quality of vision with spectacle independence is the goal. This is why refractive surgery happened to be involved with the lens, and lens refractive surgery is practiced for this purpose, and this is a new paradigm. Development of premium lenses has to be understood in this environment in which we have a change in the paradigm in the performance of cataract surgery, lens surgery, and in general in the perception of the patients why we are as surgeons obliged to do something for them. So we were studying this, and there's a sociological change that was published in Lancet by us. This is a paper that we published about the change in the paradigm. It was detected by us, and in this reference is important because it really is an historical change in what we are receiving from the patient as a demand. So we have to define, or to redefine again, which is the purpose of our surgery on the lens. And in order to do that properly, we need to remember what is aging and the decadence of the human crystalline lens, which is indeed what happens to be today the topic of this session. We define, as far as in 2005, in the aging of the crystalline lens, and we published for the first time a paper in which we describe this decadence according with the vision. We choose patients from 8 years to 80 with 20/20 vision, and as a matter of fact, not evident cataract because the vision was good. And we could demonstrate in this paper published in ophthalmology that there was a change along life and with a progressive decadence in the optical properties of the cornea associated to the change that later on was demonstrated in the Harrier or the aberrations. Here you have the course that we published in 2005 about the MTF obtained using the optical quality analysis system in patients from 8 to 80 years of age. And as you see, the MTF changes along life, and this change happens at different layers of the eye. It's not only in the nucleus, and this is getting a moment in it's about from 40 to 45 and precisely about 43, in which the decadence increases logarithmically. This is important because it's a sudden change that happens at the moment in which presbyopia is happening. So all these changes related to age happens the same. The decadence in the MTF, as a consequence, the decadence in transmission of light, less effective transmission of light, higher other aberrations are increased as well, and in general, the function of the crystal lens is in decadence. And this is what we published, and it's happening in different layers of the eye, so it's not only happening at the nuclear level. So this is what is called dysfunctional lens syndrome. Dysfunctional lens syndrome is a triad of aging changes of crystal lens in which we have presbyopia, higher aberrations, and lens opacities, and these three stages will be redefined now, and I'm going to show to you how we can identify them. Indeed, we're in the fourth, was the one that was following our studies and our publications, and he published the associated changes in the higher aberrations later on in corneal ophthalmology. So the high growth aberrations are happening with time to be increasing, and it happens in all the different high growth aberrations, but especially in the spherical ones. If we want to define the dysfunctional lens syndrome by stage, we have a stage 1 in which the patient lost the ability to adequately accommodate, but still has excellent quality of image and a clear lens. And the best treatment option probably at this moment is perhaps a cornea-based procedure or intraocular lens, because we don't need to replace an element that is functioning not completely well, but is transparent and inefficient. It's a totally different issue. We work in stage 2, in which we have an early pacification that results that the lens has a decreased image quality and higher aberrations. Probably at this moment, the lens-based procedures are the ones that have to be used as far as they can improve these lost functions. And the stage 3 is when we have a negative impact on vision, and this is what we define as a modern wet cataract. Doesn't mean that we have an important loss, but as soon as we have any decay in the visual performance, in the practical terms for the daily life activities of the patient, then we have indeed what is called a cataract. If this is true, obviously we need to demonstrate that the change in high growth aberrations that happen in stage 2 can be improved with intraocular lenses. And in this paper published by Warren in 2018, it was demonstrated with the lenses that were available at that moment that are not the ones that we use today, there was a clear change to better in the performance of the lens, what means that the patient gained in optical performance of the eye with the lens replacement. With this, we have opened the story of the refractive lens exchange. Refractive lens exchange started years ago, and it started as far as 1887. Fukala was the first in Poland that had the first vision about replacing the lens in the high myop, and the Fukala procedure was performed, obviously, in a very early stage with very primitive methods and giving trouble and controversial results. The beginning of the story was this paper was published by Fukala in Poland, and he was the pioneer in lens refractive surgery. He performed the first clear extraction, and by the end of 1889, the first one was in 1887, but in 1889 he had already treated successfully 16 patients. 16 patients in which he had a decision, he never extracted the lens, and finally with atropine, the patient was 36 months waiting for the absorption of the masses. In the turn of the 19th and 20th century, Fukala pushed all this idea, even that was with a big controversy, and especially academic prominent ophthalmologists like Donders and Bongrave were against this procedure because after almost 3,000 patients operated in Europe along the turn of the century, retinal detachment was described between 3 and 10%. So obviously at that moment, we had the consequences of refractive lens exchange. Remember, Focala was doing that in the high myop, and this was the first time that ethical performance and convenience were confronted. So Focala should be acknowledged and refractive lens exchange as the first refractive surgical procedure as early in 1887. From that moment, we had a development of all the different techniques in the cornea, and later on it was in 1989 with Franco Bercel in Italy and Joaquin Barraquer in Spain developed with extracapsular extraction more adequately and using intraocular lenses this technique in the MIP and other refractive errors as well. And it was 1993 with modern phaco modification performed by Lucio Burato in Milano that this became universally accepted, and even that controversial was progressing and indeed is in the stages that we have today with the development of premium lenses. So where we are now in 2025. Today, lens surgery is a routine procedure for cataract surgeons. The dysfunctional lenses indeed can be improved with adequate lenses that we can adequate and even customize to the optics of the eye. And we can recover all dysfunction except accommodation, even that some accommodated lenses are now being appearing in the market. The refractive outcome of the lens is very good, and we can calculate it with very high precision as far as we had adequate formulas that does a very good job in standard and non-standardized. And we have new intraocular lenses that can restore the near vision performance using not accommodation but pseudo-accommodation and multifocality with relative success. And we are now in the development and early stages of new accommodative lenses that are appearing in the market. For all these reasons, refractive lens exchange is becoming more and more popular, but we need to acknowledge that there are limits to the performance of this surgery. One of the popularity issues that have pushed refractive lens exchange is indeed the precision, the performance, the skills, and the quality that we have in cataract surgery with modern phaco devices. These devices are available to all surgeons, cataract surgeons, and a cataract surgeon is really with a tremendous instrument in his or her hands in order to improve the quality of the eye by refractive lens exchange in moments in which the decay is evident, or in moments in which the compatibility of this technique with the outcomes that can be used for refractive purposes are adequately accomplished and demonstrated. So refractive lensectomy has pros today as the ability for every good surgeon and properly trained, in which the skills of cataract surgery has been properly developed. We have the availability of this procedure for every cataract surgeon with no extra investment. We can accomplish a broad correction of refractive errors with the different type of lenses that we have today. The calculations formulas have been very much optimized. And we have available multifocal presbyopic lenses that even that are multifocal and extended depth of field and accommodative coming soon, they are indeed making a very good job in most of the cases if adequately selected. We have on top availability lenses in an unlimited range. These are the pros, but what about the cons? We have to remember that still we have intraoperative complications with postoperative infections that are rare but happens. Loss of accommodation is indeed a major issue. We cannot restore accommodation so far, even that new lenses accommodating are coming with important body of evidence in favor. Posterior capsular ossification still exists, and we induce changes in the vitreous cavity that can lead to retinal detachment and macular disease that have to be taken into consideration in high-risk patients like the MIP. And indeed, we have to balance why we use this technique instead of other surgical available alternatives with the same refractive surgery with good results as well. So the debate today, and is the reason of this session, is how to balance today the convenience and ethics in the indication of refractive lens surgery. We have to understand the outcomes, the limitations, the complications, and to compare them with other alternatives that we have for the correction of refractive errors. The refractive lecture today has to consider the indication, the risk exposure, the choice of the most adequate lens, the surgery, the outcomes, and finally, to accomplish accommodation is the final goal and the holy grail that has to be accomplished, and we are at the early stages in which this can be obtained. So conditions for the success are these the ones that I'm mentioning to you. Balance indication, which is the reason of this symposium, top quality surgery. The target now is symmetropy and aesthetically independent at all distances. And we need, of course, to get all this, improving the quality of retinal image and not degrading it with lenses that even that provide near vision aesthetic independence is at the cost of quality of retinal image. So we need to know the real performance of different premium lenses in order to make this possible. And finally, I recommend to you to read this paper that we published recently in the European Journal of Ophthalmology about the refractive laser exchange. Where are the red lines? And I hope that we can help to redefine the red lines today with this symposium, in which we are going to put into the scope refractive laser exchange for myopia, hyperopia, in the different ages in order to accomplish the best outcome possible in the benefit of our patients. So take-home messages are really that ethical boundaries are at this moment relatively blurred, and the risk factors and age limits are at this moment necessary to be redefined. Refractive lens outcomes are good and ethical, provided that indications are appropriate. We need hyperopic, myopic, and astigmatic patients to be considered differently because they have different risk factors, and the surgery should be personalized for these patients, and surgery should be granted with state-of-the-art care before and during the surgical procedure, with ethical-based algorithms guiding surgeons to practice this refractive laser exchange on the proper conditions. We have a full chapter about this topic in the new edition, which is the third edition of this book, about multifocal intraocular lenses that are the practice that I co-edited with Joseph Piquel, and will be available in September this year. And in our online course with 500 hours of teaching activities in English, we have extensively treated this important topic with this university certified course that you can follow, as you see here in our university online. And thank you very much for your kind attention.
Thank you very much, Professor